Okay. Okay. It's about 3 people on there now.
Who's moderating this?
Ellis, I take that's you?
It is.
Okay.
But who is your moderator?
President and myself.
Oh, okay.
Hi, Mr. Lavender.
How you doing, Dr. Clausen? How you doing?
I'm good. How are you?
Good. I'm waiting on Sarita to come on.
Hey, how you doing, Coach?
Yeah, we're just texting. I think she's logging in right now.
Okay. I'm gonna hang up, Sarita. All right, Brother Simmons, waiting on Dr. King to come in.
Hey, how everybody doing?
Good, good. How's everybody?
Good.
Hold on. Hello? Can you get in? Hold on.
Brother President, is just so you know, this is streaming through Restream.
Okay,
So there is so it is live streaming as well.
okay.
All right.
Brother O'Brien, Brother O'Brien, can we record?
Yes,
Can we record this if you want to? Can this
it's
be
being
recorded?
recorded.
Okay. I'm waiting on Dr. King. She's had trouble logging in.
God, I finally got to do all the other stuff, but yeah, it'll be over probably in about an hour.
Hey, brothers, y'all might want to mute yourself when you come on. Hope everyone had a great day today. Give us one more second. Once Dr. King gets on, then we'll go ahead and get started.
Okay. There she is.
All right, we ready?
Yes.
Okay.
Who's over there? If you want to sit
All right. Good afternoon, everyone. My name is Michael Simmons on behalf of the Brothers of Alpha Phi Alpha Fraternity Incorporated. The Alpha Chi Lambda chapter seated in this great city of Augusta. I'd like to first of all thank Dr. King and Dr. Clausen for sharing this great information with us tonight, and to also welcome you all as you listen in with us and learn with us. Gonna go ahead and turn it over to Brother Patrick Outler so he can give us the invocation.
Good evening, brothers. Good evening, guests. Can you all hear me?
Yeah.
Yeah.
Alrighty, let us pray. Oh Lord, our Lord, how excellent is your name in all the earth. Dear Father, we pause at this moment just to tell you thank you. We pause to tell you how good and wonderful you are. We thank you for this day, for it is the day that you have made, and we choose to rejoice and be glad in it. God, we thank you for each and every brother, and we thank you for our presenters on tonight. We invite your presence into this presentation. Let it be enriching and enlightening, that we all may strive to live by what is being presented on tonight, that it may be helpful to us in our everyday living and our communities. God, we praise you. We give your name the glory, the honor, and praise. It's in the name that's above every name. In the name of Jesus, we pray. Amen.
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 My name is Philip Lavender, and I'd like to introduce our guest tonight to us. First, we have Dr. Zachary Clausen. Dr. Clausen is a native of Canada. He grew up in British Columbia, Canada. He followed his undergraduate degree in biology and microchemistry from Simon University. That's in Grenada. Dr. Clausen has a philosophy that was very intriguing to me. He believes that the cancer journey that he does is not only with the patient, but it's also with the family. He focused on the treatment of cancer outside of the diagnosis. He believes that the physical and the emotional conditions are very important in there. His specialties are he's a urologist. He does the robotic surgeries, and he's and the cancer surgery. As for Dr. King is almost a friend of mine, a long friend of mine. Is that I kind of knew her, but I didn't. I knew her after she came out of her mother's womb, in a sense. She and I was from the same part of the country in Washington State when she was born. But she's an exciting young lady. She works in 2 areas here in Augusta. She's in the Augusta Medical Center and the Charlie Norwood VA Center here in Augusta. She has a degree from the Medical College of Georgia, and she has been practicing about, I can believe it, somewhere between 11 to 20 years. She's a urologist specialist. She concentrates on the female and male reproduction system. She's a board certified urologist here, and she's a licensed urologist in the state of California and in Georgia. Without that, Dr. Clausen, I'm gonna ask you to go first and just talk to us about prostate cancer and cancer itself.
Yeah, thank you very much, Mr. Lavender, for that phenomenal introduction. And whoever's the host, if they can enable me to share my screen, I'll pull my slides up. While we're doing that, Dr. King and I go back nearly a decade now. She was 1 year ahead of me in residency. We were co-residents together here at MCG, and now we've been partners in crime. for, I just started my 5th year, so I guess you just started your 6th year.
Yep.
Um,
Here.
and we've been doing, we call it the, what's sort of our theme? I guess basically she's the good cop, I'm the bad cop. So I'm gonna hopefully cure your prostate cancer, and then she's gonna take care of all the stuff that also matters as well. So we'll kind of go through some of that together tonight. So we've really enjoyed doing some of these talks in the community. I think this is probably what, our 4th or 5th one, I think, in various formats. And I would really like to thank Mr. Lavender and the Alpha Phi Alpha chapter here in Augusta for giving us the opportunity to talk tonight. We've been looking forward to this for several months, and I know the pandemic, like a lot of things, put a damper on some of this, but it's great to be back and have these opportunities. So I'm going to talk about prostate cancer and screening and some of the treatment recommendations we do. And essentially the message today is basically early detection is what we're looking for. And I think we're going to talk about the prostate cancer journey, but importantly, we're going to talk about how getting your numbers checked, seeing your doctor, talking about who's eligible, who should be getting screened, when to get screened. And more importantly, you guys are the flag bearers for telling your friends and family members as well. So this is a important aspect, and we'll talk about that tonight. So thank you very much again. So I call this Prostate Cancer 101. We're going to talk about several different questions and sort of break it down, as you can see here in the outline. How common is prostate cancer? What is prostate cancer? Do we know what causes it? What are some of the risk factors for prostate cancer? Can it be prevented? What are the symptoms that may be associated with prostate cancer, or what may be associated without prostate cancer, just having an enlarged prostate that is not prostate cancer? We'll talk about the tests that find prostate cancer early. We'll discuss some of the treatment options. We'll discuss what you can do, and I have a slide at the end for more information on some of the things we talk about today. So prostate cancer is the most often diagnosed cancer in the United States. And so we see about 1 in 7, 1 in 8 men will have prostate cancer during their lifetime. And for reasons that remain unclear, it occurs more often in African-American men than any other group in the United States. It's the second leading cause of cancer-related death in men in the US. But as I alluded to at the beginning, when detected and treated early, nearly 100% of men will be alive 5 years, and many more beyond 5 years. What we've seen in the last decade or so, since we've finished residency, is the prolongation of life, even after multiple treatments, 2nd, 3rd, 4th line, is getting up to a very long latency period and a very long quality of life with longer life, even in advanced stages of prostate cancer. So a lot of research and a lot of trials have improved this even over the last 5 or 6 years. So what is the prostate gland? So the prostate gland is only found in men. It's part of the reproductive system and helps make semen. And the way I explain it is that once you're finished having your kids, the prostate gland is really just a problem. So either it leads to cancer, or it leads to benign growth, which we'll talk a little bit about. But once you're finished having kids, it's basically just a nuisance. It sits between the bladder and the rectum. So the rectum is where you poop from here. And you can see your urine channel here. This is where the prostate gland sits. So you actually urinate through the prostate, and it sits kind of in between the bladder and the rectum. A healthy prostate gland, it's about the size of a walnut, but as we grow, I tend to say that the prostate's like your ears and your nose. It tends to grow with age. And certainly some men will have symptoms of an enlarged prostate, even though it's not physically that big. Some men have a gigantically enlarged benign prostate, which is not cancer, and they have no symptoms at all. So everybody's a little bit different. But you can see this aspect of actually urinating through the prostate gland as depicted in this slide at the bottom. So what causes prostate cancer? We don't actually know what causes prostate cancer. Like most cancers, we think it's probably related to your genetic material or your DNA in your cells, which may change over time, and that may be related to some of the factors that we'll discuss on subsequent slides. The DNA changes or your genetics are passed down through your family, and so this can be one cause of prostate cancer. It's a genetic or hereditary aspect, or it can occur due to environment or lifestyle. So in terms of risk factors, age is probably the most important risk factor. This is a cancer that typically happens in men in their 60s and 70s. Occasionally we see it in their 50s and 40s, but for the most part, majority of men will be older than 50 years of age. In terms of race and ethnicity, African American men and Caribbean men or men of African ancestry have the highest risk, which is about 1.7 times higher than Caucasian men. And the reasons for this are unclear, but again, going back to likely DNA changes. Importantly is knowing what your family history is. So if you see me or you see Dr. King or any other urologist or primary care doctor, they're going to ask you if you have any relatives that have prostate cancer. So we know that men that have a father or a brother, so these are first degree relatives, this more than doubles a man's risk of developing prostate cancer. Importantly, it's, you know, even uncles and keeping track of how many uncles or brothers or your father have prostate cancer is important, because with each successive relative, the risk increases. And this also kind of depends on how old they were diagnosed. If men, if their father was diagnosed at 75, it really doesn't lead to increased risk for yourself. But if your father was 52 years old, certainly somebody in their 40s needs to be thinking about getting screened for prostate cancer because of the age of what their relative was diagnosed. So in terms of genes, some inherited genes do raise the risk of prostate cancer, but for the most part, this accounts for a very small risk. There's genes called the BRCA mutations, which you may have heard in the female cancers such as breast and ovarian. There's some relation to that in prostate cancer, but this is a very small minority. And for most of these genes, genetic testing is still sort of being developed at this point. Diet's important. So this is important not just for decreasing potentially your risk of prostate cancer, but importantly, this is improving your cardiovascular health. And this is something I talk about in the clinic a lot. So we all know that the number one cause of mortality or death in the United States is cardiovascular heart disease. What's a little less known is that even among men that have prostate cancer, so prostate cancer survivors, of which there's 3 million in the United States, even among these men, prostate cancer is not the most common cause of death. It's still heart disease. So when men come in, they say, "Doc, my prostate number is up a little bit," which we'll talk about. I'm worried about this. What can I do from a diet standpoint? I always talk about heart healthy diet, because at the end of the day, whether you have prostate cancer or don't have prostate cancer, a heart healthy diet is going to be the most important aspect of preventing, certainly preventing heart disease, but maybe preventing your prostate cancer diagnosis. So because the exact cause of prostate cancer is not known, at this time, it's not possible to prevent most cases of disease. We do know that there's such risk factors such as age, race, and family history. We can't control those, but there's been several studies looking at supplements and vitamins. Typically, these don't, in these trials, they have not decreased the risk of supplements. And generally, this should be something you talk about with your primary care doctor, because there may be other risks or benefits associated with taking these. But in terms of actual supplements, there's been no data, even though there's been several trials that have not proven to show benefit for prostate cancer prevention. So symptoms of prostate cancer, most men, especially with early detection, have no symptoms associated with the disease. You may have friends, or you may yourself have urinary symptoms such as slow stream, getting up at night to go pee, failing to feel like your bladder is completely empty. For the majority, if not the vast majority of these situations, this is due to benign or non-cancer growth of the prostate. So this is just a big prostate. If you think back to the image I showed in the beginning of the talk, you have to urinate through your prostate gland. So if those lobes on the inside are blocking the channel, it's going to make it difficult to pee. You have to generate enough pressure to release the urine from the bladder. And the important thing is that this is typically not related to cancer. It's more related to benign growth of the prostate gland. Now, there is certainly symptoms of prostate cancer, especially in the advanced stages. And so this is likely secondary to when the prostate cancer, if it's untreated, moves outside the prostate. And this can lead to the prostate cancer being in the spine or in the pelvic bones. This can lead to pain in those areas. This can lead to leg weakness, low blood counts or anemia, which lead to tiredness, unintended weight loss. And these symptoms are in the untreated advanced stages of prostate cancer, not in the early stages, which is the most common when it's diagnosed. In terms of prostate cancer screening, so screening is essentially defined as testing to find cancer or other diseases. So we do have two common ways that we screen for prostate cancer. The most common one is the prostate specific antigen, or the PSA blood test. You may have be familiar with that terminology. The other one is the finger test, the digital rectal exam. Nobody wants this test done, but it's an important part of a man's health. So feeling the prostate, feeling if it's smooth, if it has nodules or pebbles or rocks or soft, this is all indications to your doctor whether there may or may not be prostate cancer, regardless of what the blood test shows. So when a man comes in for screening, this is usually the two things that we do. A little bit more about the PSA. So the PSA is a protein. It's made just by the prostate gland. There's no other cells in the body that make it. And most healthy men have a small amount of PSA in the blood, which is usually less than 4 nanograms per milliliter. So if you get online and you start looking about what's a normal PSA, you're going to see a range typically from 0 to 4. And those are good numbers to remember. In clinical practice, this does change a little bit. It may change a little bit based on a man's family history. It may change more commonly based on how old they are. So a man that's 55 years old, a PSA of 4.5 is elevated. If you get into your 70s and 80s, that number may move up to 6 or 7. So it is age dependent, at least in my thought process. And this is basically trying to decide if we need to do a biopsy to rule out prostate cancer. If a man comes to me with an elevated PSA, it doesn't mean that he has prostate cancer. I typically explain that it's related to 3 different potential reasons. One is prostate cancer. The second one is that a man just has a big prostate gland. A big prostate gland is going to make more PSA. Then the third one is that there may be some inflammation or even an infection that you may not even know that you have in the prostate that's making that PSA go up. So just because the PSA is elevated doesn't mean you have prostate cancer. It means you need to probably have a discussion with your urologist about whether they think it's reasonable to undergo a prostate biopsy to rule out prostate cancer. A little bit more about screening. So generally, the AUA is the American Urology Association. These are the guidelines they have for us as urologists with regards to PSA screening. Now, this is not the Bible. This is recommendations. So each man's situation, whether it be a strong family history, may dictate whether we start screening earlier than even what these guidelines recommend. But basically, the guidelines say that most men under the age of 40 do not need screening for prostate cancer. And even among men 40 to 54 years of age that are average risk don't need prostate cancer screening. However, as I mentioned before, if your dad was 52 when he was diagnosed, we typically move that back 10 years so that the son of that man probably needs prostate cancer screening in his early 40s. So this is average risk. Generally 40 to 54 years does not need prostate cancer screening. The sweet spot is 55 to 69. So this is where the benefits of reducing the risk of detecting disease that is spread outside the prostate versus the potential harms of treatment and diagnosis are kind of equal. And we call this fancy term called shared decision making. And basically, that's a conversation between you as the patient and your doctor about what are the risks and benefits of undergoing screening, potentially undergoing a biopsy, and what that entails if there's a diagnosis of prostate cancer that's found. There's several other recommendations. So if a man has a low PSA, the AUA recommends that we may be able to check it every 2 years instead of annual to reduce the burden on the patient. Generally, there's less recommendation for screening in men over the age of 70. However, I like this anecdote that they put at the bottom, or men that have 10 to 15 years of life expectancy. So if a man comes in, he's 75, he's running marathons, that guy probably is going to live to 95, all things being equal. So that guy may benefit from screening. So we don't put a hard cutoff on the age, but generally 70, or if you have other health issues that are potentially life-threatening, we may not recommend screening at that point in time. So these are guidelines. They're not in concrete, but this is some of the things we think about when we're looking at men that may benefit from screening. So what do men need to know about making an informed decision about testing? It's important to know that not all prostate cancer is life-threatening. So there's a vast spectrum. We see it in the clinic every single week. Men that have a very low volume of very non-aggressive prostate cancer that we monitor, all the way to men that come in with a PSA that's over 1,000 that have already had the disease spread to the bones and lymph nodes and other organs such as the lungs and the liver. So it's a very wide spectrum, and the goal is that it's not always life-threatening. The majority of these will grow slowly, but it doesn't take away from the fact that early detection, especially in men in their 50s and 60s and men with a strong family history, allows us to have these discussions about who may benefit from treatment. It's important to note too that many men who have prostate cancer will die of other causes, so heart disease, other comorbidities they may have in terms of lung issues. We all got to meet our maker somehow. The goal here is not to die of prostate cancer, and that's where the understanding the risks and the benefits of early screening and detection is important. Testing clearly helps some men, but in others it leads to diagnosis and treatments that would never cause them harm. And this is where I come back to the spectrum of very low risk, very low volume, non-aggressive, non-life-threatening prostate cancer may just be watched versus men that come in with a very high PSA that was not detected early. Prostate cancer treatment does have side effects such as erectile dysfunction or inability to have adequate sexual intercourse, incontinence, or leakage of urine, which can have a major impact on a man's quality of life. And so this is where the over-treatment of disease that is unlikely to be life-threatening is important, because the side effects of treatment are real. Dr. King's going to talk about them and how she fixes them. But certainly having this discussion with your physician and getting second opinions and talking to your friends, family, church members is important once you have the diagnosis and the treatment options are put in front of you. So the only way to diagnose prostate cancer is to do a biopsy. So this is basically taking little pieces of tissue from the prostate gland and sending it to the pathologist, who then looks at this under the microscope. And the way we do this is we give you some lidocaine numbing medicine through the rectum, so through the backside. We take a little ultrasound probe where we can see the prostate gland. As I showed you on the first couple of slides, the prostate gland sits very close to the rectum, so we can see the prostate very well with an ultrasound. And then we take 12 to 14 pieces of prostate tissue, very small pieces, that we then send to the pathologist. So if it shows prostate cancer, we then lead to the treatment discussions that we have. So very generally, there's essentially 3 treatment options that we have for prostate cancer that is just in the prostate gland. One of them is we just monitor it. As I mentioned before a couple times, is that some of the low grade, low volume prostate cancer that's not life-threatening, we can watch it. And the reason we watch it is not to ignore it, but to spare side effects of the sexual dysfunction and the urinary incontinence. I would say that among the men that I have on active surveillance, about 60% will never need treatment, which is great. They're not going to die of prostate cancer. They're not going to need treatment that can lead to side effects. Over time, 40% or so will need treatment, but they may get 4 or 5 or 6 years where they don't have the side effects of the treatment and they still have an excellent quality of life. So the men that fall into this category depends on your age, depends on your overall health. I have a discussion about what my thoughts are in terms of the likelihood of needing treatment going forward. The other 2 options are the standard treatments for localized prostate cancer, so surgery. As Mr. Lavender alluded to, we take the prostate out. Majority of these are done with a robotic technology, so small incisions, very precise movements. And this is typically either a same-day surgery or overnight in the hospital, where we remove the whole prostate gland, and the whole prostate gland gets sent off to the pathologist for analysis. The third option is radiation. So this is non-invasive treatment, where basically the radiation oncologist will direct radiation X-rays to the prostate with actually quite good accuracy. And this kills the prostate cancer cells in the prostate gland, but does not remove the prostate gland itself. So in men that are older, typically in their maybe late 60s, early 70s, or men that are not healthy enough to have anesthesia for a surgery, we will typically do radiation, as the risks of the anesthesia and the surgery are higher than if we just do the radiation without having to put the patient to sleep. So after treatment, as I mentioned before, you join 3 million prostate cancer survivors. As Mr. Lavender knows and Dr. King knows, that we call this the prostate cancer journey. And the journey starts at the time of diagnosis and it continues on for the rest of your life. And based on early detection and excellent treatments in the advanced state, As we see here, there's 3 million people living with prostate cancer or treated with prostate cancer that are alive and doing well in the United States. We do continue routine follow-up. I typically never will discharge a patient from my clinic with prostate cancer because I feel like even if they're 10, 15 years out, a blood test once a year and a handshake and a hug is worth a 10-minute visit just to make sure that this hasn't crept back up even in the decades after treatment. Then after the treatment's all done, and even sometimes beforehand, we'll get you over to see Dr. King, especially in men who are sexually active and men that are very on top of things and who want to get on things early. We'll have you see Dr. King before any of the treatment happens. Some men like to wait till after the treatment's done. They'll see Dr. King afterwards. But I would say at this point, Dr. King, we share hundreds of patients at this point. So it's a very tight-knit group, and we get you over to see her as quickly as you'd like, essentially. So in terms of early detection of prostate cancer, men should take part in this decision to be tested for prostate cancer by learning about prostate cancer, such as these events tonight, the pros and cons of early detection, and the treatment of prostate cancer if you are diagnosed with it. What you can do, certainly talk to your doctor, your primary care doctor, your urologist, your internist about your risk factors and what you can do to potentially lower your risk. Starting around age 50 or earlier, if you have a strong family history, talk to your doctor about whether you want to have prostate cancer screening tests. And as I mentioned at the top, tell other men about the importance of talking about this with your physician. Most family practitioners are excellent, but they're thinking about diabetes, high blood pressure. They're talking about colonoscopies, and it's important to take an active role in your health, and knowing your risk factors and knowing your age and your family history can certainly generate that discussion with your doctor early. We have certainly some excellent information at the Georgia Cancer Center, and I'm happy to send Mr. Lavender these slides to distribute to you guys with these websites. I always direct people to our website. American Cancer Society is also very good. Dr. King and I have partnered with the Prostate Cancer Foundation, and they're building a phenomenal initiative and a website called Cancer Patient Voices, where we've written articles and had interviews with several folks with regards to their journey. And we've written these for the patient level. So a lot of the stuff that we discussed today, hopefully in the next 6 to 8 weeks, this website will be launched, and I'll surely share this with Mr. Lavender, who can distribute to you guys. Because think among these 60 or so, 500 to 800 word articles, there's going to be some excellent information about all these things we've talked about for the patient level education as well. So at that point, I'll be happy to take any questions. If you want to do Dr. King's first and take questions then, I'm happy to do whatever is best for you guys. Thank you very much for your attention, and I look forward to the discussion.
Thank you. Dr. Clausen, I have one question.
Sure.
A lot of people have asked me this, and I did not know the answer to this. If you select to do the radiation treatment, is it possible to go back and get the prostate removed?
It's a great question. So the answer is yes. I will say that this is a discussion I have not infrequently in the clinic. The surgery after the radiation is certainly much harder. The radiation shrinks the prostate. It makes it very sticky to the surrounding structures, such as the bladder, the rectum. There is people in this country that do what we call salvage surgery after the radiation. I find that it's significantly higher risk of getting into a rectal injury during the time of the operation, which can be devastating to a man who has to have a colostomy after the operation.
Mm-hmm.
Certainly the chance of leaking urine is nearly 100% after that. It's hard to save nerves that help with the continence mechanism. Essentially 100% of men will have sexual dysfunction after a salvage operation. Again, those nerves where they run nicely along the prostate, after you've had radiation, everything sort of, for lack of a better term, becomes fried to the prostate.
Okay.
And so it's feasible to do the operation, but it's the side effects that we talked about are all significantly worse after that.
Okay.
What I typically will do in those situations is not necessarily take the prostate out. If somebody's had radiation early and the prostate cancer does come back in the prostate gland, I'll do what's called salvage cryoablation. Essentially, this is just freezing the prostate. So it's not removing it, but we'll freeze the prostate cancer areas as well as the other areas of the prostate, trying to limit the side effects that may be that may happen if we were to take the prostate gland out. It's a good question.
My name is Holmes, Johnny Holmes, and I do have a couple of questions.
Yes, sir, Mr. Holmes, go ahead.
Okay, first, a large prostate, does that lead to prostate cancer?
It's a good question. The large prostate does not necessarily increase the risk of prostate cancer. It does increase the likelihood that you may have some problems with urination or peeing in the future, but it's typically, we think of it as prostate gland causes two problems. One of them is prostate. One of them is the issues with urinating. Occasionally, men will have a big prostate and have prostate cancer in it, but it doesn't necessarily lead to the other.
Okay. Now, other question, does finasteride, is that for long term or should that be for short term?
It's a great question. So Dr. King's heard my talk about finasteride a couple of times. So we've got some very good data going back to the early 2000s that finasteride shrinks the prostate gland down over time.
Right.
And it also helps with urination over time. The problem with finasteride, in my opinion, and the older generation of urologists gave finasteride all the time. I don't typically prescribe finasteride. If somebody's on it and they're doing well, I'll keep them on it. I have no problem with that. The reason I don't prescribe it is because I think the side effects of finasteride typically are worse than what the benefits are. Breast tenderness. Some people describe sort of this brain fog when they're on finasteride. If men have difficulty with urinating, I'll put them on something called Flomax or tamsulosin, which basically relaxes the prostate muscles, allows the urine to pass through a little bit easier. I find that works very well on its own. And if that doesn't work, there's other more invasive treatment options. But finasteride's a tricky one. It's fallen out of favor, I would say, a little bit in the last 5 to 10 years. Dr. King may be able to add something to that as well. But
Yeah, I hate finasteride. So all those things that he discussed, talking about like the brain fog and the other issues that come from finasteride, when you cluster those together, we call that post-finasteride syndrome. And other things that can happen. Some people have problems with ED, even though to stop having low T or testosterone won't cause you, or won't really cause your ED, but it kind of plays a role in it because it messes with your libido, it messes with your well-being, because it's preventing your testosterone from being converted over to a hormone called DHT, which is what your body actually uses to get the effects from testosterone. So I am personally not a fan. I do not give it out. If I see somebody on it, I try to get them off of it. Like he said, there's lots of other medications. Another medication that I'm using a lot now is tadalafil, which is generic for Cialis. I'll do the 5 milligram dose. That has been shown to help with BPH symptoms or enlarged prostate.
Okay.
And that has less sexual side effects. So,
okay, thank you. And my final question, can you have prostate cancer with a low PSA?
It's a very good question. The answer is yes. And so the reason that we talk about the two screening mechanisms, one of them being the PSA blood test, the other one being the rectal exam, the finger, is because even if the PSA is say 2 or 1.5, which is a normal range, if we feel something on the rectal exam that feels suspicious, feels firm, there's a nodule, feels like a pebble in the prostate, we'll recommend a biopsy just off of that rectal exam alone, regardless of the prostate. And we will occasionally find prostate cancer if the PSA is low and the rectal exam is suspicious. So it's not super common, but we do find some prostate cancers just based on the rectal exam, even though the PSA is low.
All right.
Wyman Smith, I just want to have one question, couple questions. Yes,
Mr. Smith.
Yes, to either one of you. A lot of times I'm in that over 70 group. I go to VA, of course. They do tests occasionally. My PSA is, it's pretty good. I think the last one was something like, I'm looking at it now, something like 0.763.
Mm-hmm.
Is that good or bad? I see Dr. King shaking his head there a little bit. I don't know if that's
no, I said that's great.
That's great.
That's amazing.
That's great. Yeah,
but But in other words, I was just thinking, because a lot of times you get these symptoms, they kind of overlap with something else. A lot of times I'm in that over 70 group. Once again, you go to the bathroom to pee. It's not as quick as it used to be. Of course, you might stand there for a few seconds before you get, it concerns me, of course. And I'm not sure, should I be concerned, or that's just, I'm in the over 70 group. So that's the reason it's hitting me now. It's like that.
Yeah, I think it goes back to a couple of my slides are where even though the PSA is normal and your risk of prostate cancer is extremely low at over 70 in the PSA that you have, as we get older, that even if that prostate gland isn't that enlarged on the outside, if it's enlarged on the inside, it's blocking that channel.
Okay.
It can still lead to the symptoms, but very unlikely that it's prostate cancer, more just related to the growth on the inside leading to the blockage. The other thing I'll mention too, and it's important because it gets lost in the weeds sometimes. The bladder can be affected by several things as well, and one of those is diabetes. And so if the blood sugar is not perfect, that leads to a weak bladder, which has a very similar symptoms of not being able to get the urine out, just like if your prostate gland was enlarged. So I think don't forget about the sugar control, because that affects everything, as Dr. King will talk about sexual function, but certainly it affects the actual function of the bladder, the ability to squeeze to get the urine out as well.
Okay, I am type 2. Okay, so that's okay. Thank you.
You're welcome.
I have one other small question, and I'd like for you to kind of talk about it if you could. After a person has been diagnosed with prostate cancer, they go to the thing of what they call the Gleason scores.
Yes.
Could you kind of explain that to us?
Yeah.
And the importance of those numbers and how it kind of stacks up.
Yeah, great points, Mr. Lavender. So when we send off the prostate tissue after a biopsy, the pathologist will give us a result of cancer or no cancer. No cancer, great news, fantastic news. If there's cancer there, they then give us, as Mr. Lavender said, the Gleason score. So the Gleason score is made up of two numbers. The first number is the most prevalent, or the most number of cells that they see under the microscope, and the second score is the second most common. So let's say somebody has Gleason 3+4 prostate cancer. We call that intermediate risk prostate cancer. That means that the majority of the prostate cancer is 3, which is a low grade, but there is some of this pattern 4, which is more the intermediate grade. So we call it a 3+4. So if we break it down sort of overall, the majority of the cancers as they score them will be either a 3, a 4, or 5. And they'll give you two numbers. So you get all those combinations: 3+3, 3+4, 4+3, 4+4, 4+5, 5+4, and 5+5. So that gives us an idea of the aggressiveness. Low risk being Gleason 3+3, PSA is less than 20. Intermediate risk being 3+4 or 4+3. And then high risk being 4+4 or higher. All those other combinations. There's a few more nuances, but generally this gives us an idea of a low, intermediate, or high risk based on what the pathologist is telling us.
Okay.
And in that website I talked about, that's going to be coming from the Prostate Cancer Foundation, we've got some excellent articles that are going to go into this in great detail, and I think it's really going to explain it nicely. So I'll definitely send you that link once we get it.
Yeah. Thank you.
Yes. Good questions.
Any other questions?
I have one other question.
Yes, sir.
A gallstone in the bladder, I was told that if it's not bothering you, don't really worry about it.
A stone in the bladder?
Yeah.
Yeah, it's a good question. So the stone, typically, if you have stones in the bladder, it's usually due to urine sitting in the bladder. And that may be from the prostate being big and just not emptying properly. It may be from the bladder not working properly and able to squeeze to empty. And the worry with, and you're right, if it's not bothering you, it probably doesn't need to be treated. What it can lead to is some infection. But if you're not getting the infections, there's not every stone needs to be treated, and that kind of goes for bladder as well.
All right, thank you.
They should keep an eye on it though, because it can get bigger with time though.
Yeah, it can grow.
Thank you.
Looks like Mr. Galloway has a question.
Yes, sir. Hey, how you doing? Hey,
Good.
I'm definitely enjoying this presentation. I've this past May, I had my second biopsy, which came up negative.
Right.
And normally my PSA ranges around like the 4.0. So I am being actively monitored by Eisenhower Army Hospital, and I'm just 49 years old. So I'm doing some some holistic things, like I'm taking like, saw palmetto and some herbals. What is your take on that to keep my prostate healthy? And what does your data says when it comes down to, taking like supplements?
It's a great question. So the fact that you've had 2 negative biopsies, that's great. So I think they have, my guess is with 2 negative biopsies means no cancer. They haven't missed anything serious, which is good.
Yeah.
My take on the saw palmettos and those vitamins is I guess the issue with those is that there's not a lot of high level data, so randomized trials for saw palmetto. But the way I explain it is I'll probably never prescribe it, but if men are on it and they feel like it's working, I'm fine with that. So if you feel good taking it, it's giving you peace of mind. I don't have a problem with it. I think it's one of those things that just hasn't been studied at a high level.
Okay.
To give us maybe some of the clinical data that some of the other medicines have. So
Okay.
one thing, in terms of your history at 49, 2 negative biopsies, have you had an MRI of the prostate in between those biopsies, or have you had an MRI?
Let me see. I know I've had the 2 biopsies, and then, the retinal. So I want to say this last time they did do the MRI, because I had an MRI this year because I had to go in where they stuck the dye in me.
Yes.
So yeah. So yeah, I remember that because I had to lie in that machine for about over an hour. So yeah.
Yes. Good. The reason I asked that is because the recent guidelines say that if you've had a biopsy that didn't show cancer, before you get the second one, we should do an MRI. The reason for that is the MRI technology has gotten so good that we can see if there's any areas in the prostate gland that we should target. So between 2 negative biopsies and an MRI, I think you're in a good spot.
Okay, and I am taking the Flow Max.
Yes, sir.
I try to make sure I take it at a good time at nighttime because one thing about having an enlarged prostate, you do have a tendency to go to the restroom a lot more during the night, and I've had to just make some adjustments in reference to when I take it and how much fluid. So that's pretty much been helping.
Right, that's awesome. I think especially folks that like to have a glass of water or a glass of wine or beer in the evening. I typically, if you go to bed at 10 o'clock, you stop the fluids around 6 or 7. That'll help a little bit at nighttime. If you're drinking beer till 11, that's fine, but you're going to have to go pee in the middle of the night. So it's what goes in's got to come out at some point.
Yes, sir. Yeah, but thank you for the information. Great information.
My pleasure.
All right.
Nicholas? Teddy, go ahead.
Yes, good evening. Thank you. So good evening, Dr. King and Dr. Clausen. I have a question. I was wondering, what are some things that one can do regularly to maintain a healthy prostate? Like, I don't know how true this is, but I've heard that like regular sexual activity, safe sexual activity is healthy for the prostate, and of course I've heard tomatoes. But what are some other, I guess, easy to remember things that one can do to maintain a healthy prostate?
That's great questions. So I think you're absolutely right. So we had, Dr. King and I both had an old mentor of ours that used to talk about emptying the pipes, which is true. Emptying the pipes, having regular ejaculation, it keeps the prostate from being congested. Men that have pelvic pain or prostatitis, the way people get that can be very multifactorial, but certainly, lack of ejaculation could be one of those. And let's be honest, a good sexual activity is good. And as you said, safe sexual activity. And that's certainly one way to keep the prostate healthy. It's kind of one of those things, there's some folks in our field that say, decreasing spicy foods or decreasing coffee may lead to, or decreasing alcohol may lead to to prostate health or less of symptoms if you have pain down there. I mean, I'm a coffee drinker. My prostate doesn't hurt, but I love coffee. So if you told me don't drink coffee and your prostate will feel better, I'd say that's fine. I'm still going to drink 3 cups of coffee. So there's no magic bullet for everybody, but certainly things that may inflame the prostate, like they would inflame your esophagus for reflux, are probably all in that same kind of boat. But I think you're absolutely right. The sexual activity ejaculation is very good for the prostate. Do you want to add anything, Dr. King?
No, I was just going for that. You
You knew where I
gotta
was going with
pick-
it.
I was headed that way. That's right up my alley.
I stole the thunder.
I know.
That is a good segue into Dr. King.
Yeah, absolutely.
Johnny and Wyman, her father participates in our golf tournament every year. So she's a product of that's as her father. But by that way, I give you Dr. King.
All right. Let me make sure. Can somebody let me share, whoever's hosting? I think it's you, Zach. Or Dr. Klassen. It made you host.
He has to give you the hosting capabilities.
You gotta pass the bag, man.
Pressure's on.
Ooh, how do you do it?
Click on the 3 dots. Click on her name on the 3 dots and make a host.
You should be good.
Ooh, thank you. Now I'm host. All right.
It's only been 2.5 years we've been doing this. I still can't figure out how to pick somebody here.
No, it took me forever to get on. We're not gonna talk about it. Okay. All right. Let's see here. All right. Can everybody see my slides? Everybody can see my slides, okay? Good. All right, perfect. All right, so now we're gonna get to the fun part of the evening where we're talking about men's health, okay? We're gonna get real comfortable here. Yes, so my name is Sharita King. I work at Augusta University and Charlie Norwood VA. So if you have any questions, you can always come see me and seek me out. I am from Augusta. Well, I'm from Washington, as Mr. Lavender said, but I've been here in Augusta since 1989, since I was in 2nd grade. So those who know, it's the Medical College of Georgia. We don't care, right? And just had a little put a plug there. I am a member of Delta Sigma Theta Sorority Incorporated. All right, so tonight we're going to be talking about the birds and the bees for adults. Again, please leave your feelings at the door. We're going to get a little intimate here, and don't be afraid to ask any questions. So the objectives, we're going to be talking about erectile dysfunction. We're going to talk about male incontinence, that is bladder leakage. And then we're also going to talk a little bit about testosterone. So with erectile dysfunction, this is one of the flyers from one of the implant companies that I work with. And I like this flyer because it shows that, any man can be affected by this issue. So this is something that is near and dear to my heart. A lot of people ask me why I decided to go into this. Not really sure. I thought I wanted to do neurosurgery and then saw the light, and there I am. Okay, so we're going to go through causes of erectile dysfunction. So 1 in 4 men throughout their lifetime will develop this issue. It can be caused by injury to the brain or spinal cord. It can be caused by different diseases, diabetes, hypertension, heart disease. It can be caused by surgery, as Dr. Klassen talked about, with prostate. Other surgeries that can cause issues with this is removal of the bladder and even removal of the colon. And I have a picture later on that shows why this happens. It's just because of where those nerves that control erections, where they kind of live. The other thing that can cause issues is pelvic radiation. I know a lot of practitioners will tell you that, oh, if you get radiation, you won't have erectile dysfunction, or you won't leak on yourself. I beg to differ. The thing is, they're not seeing you anymore. They're going to be passing the buck on along to somebody else. And then you'll be coming to see me for these issues afterwards. Another thing that can cause problems is substance use. So that could be tobacco. So smoking is terrible for you. I have the nose of a bloodhound. I will know if you walk in my office and smoke. Other things are drugs, and that could be illicit and medications, and then also alcohol. I know in the long history of human beings, alcohol has been tied into sexual activity in some sort. Having a glass of wine or whatever is not really great for erections. So what are some of the risk factors? We have aging. So I go by what I call the rule of ages. So if you have a room full of 100-year-old, you have a room of 50-year-old men, 100 of them. How many do you think would have erectile dysfunction? So we go by aging, so it's 50%. So when you get to 60-year-olds, it's 60%. When you get to 70-year-olds, it's 70%, and it goes on and on. So just saying, not everybody is having this issue, but it definitely causes a problem. Just like we can't run like we did when we were 18. We can't expect our bodies to completely function exactly the same. The other thing is chronic diseases. So hypertension, diabetes. We harp on this a lot. And I know Dr. Klassen talked about diabetes. It's very important that you keep your sugars controlled. Yes, it will ruin your penis, but there's other things that are far more important that it can ruin. And that would be your eyes, your heart, your kidneys. You can have bladder issues. So it's something that we really need to make sure that we're taking care of. Other things like depression can cause problems. And this can be twofold. It could be from the depression itself, or it can be from the medications that treat it. And then, lastly, in the chronic diseases is cardiovascular disease. So this is huge. With cardiovascular disease, the penis is the canary in the coal mine, and I have a slide about that later. So medications that cause issues. The most notorious ones are the antihypertensives, so medicines for your blood pressure, beta blockers and thiazide diuretics. So it's like hydrochlorothiazide. Those things definitely can cause you to have problems with erections. And that's just because you probably already have some narrowing of the arteries, and now we're lowering your blood pressure, so the blood is not able to get to the penis like it did prior to you starting the medication. Even though it causes erectile dysfunction, it's important to remember that you should stay on these medications and not stop them without consulting your physician. And then lastly is lifestyle, so that's stress. The penis operates under what we call the parasympathetic nervous system. So that's a nervous system that is activated when we're relaxed, right? This is for evolutionary purposes, because if you were a caveman and you're having intercourse and a saber-toothed tiger jumped out of the woods, you need that erection to go away so you can get out the way, right? So that's fight or flight, because adrenaline is being released, and that's stress. So the same thing happens when you're stressed out with work, with life, with family, with home. All those things lead to stress, which will counter anything that you have going on with erections, even most of the treatment options that I have. Again, alcohol is terrible. I mean, it's okay in moderation, but if you're abusing it, you'll definitely have issues. And then smoking, you'll have narrowing of your arteries and hardening of the arteries with that. All right, so I kind of alluded to this about ED being the canary in the coal mine. So I don't know if you ever heard of this saying, but back in the day, coal miners would take canaries down into the coal mine with them. So if the canary keeled over, that means it's time to go. That means there's problems going on in the in that coal mine. So a lot of men won't go to the doctor for a lot of things, but erectile dysfunction is one of them. When their penis stops working, they're going to figure out a reason to fix, or figure out a way to fix this. And the reason why this is a canary in the coal mine is that the penis is a very vascular organ. It has a lot of blood flow that's going to it. That's how erections occur. When you have loss of erectile rigidity, it's one of the earliest signs of endothelial dysfunction. So that just means there's something going on with those arteries. And that endothelial dysfunction is an early marker for cardiovascular disease. And the reason why we see it in the penis before we see it anywhere else, like the heart or anything else, there's a little animation of the canary running, is because the arteries in the penis are a lot smaller, as you can see from this schematic. So they will notice, or that you will be able to notice a difference in the change in the caliber or how much blood can flow through those arteries. All right, so now we're going to talk about prostate cancer treatments. So remember Dr. Klassen's talk, he talked about the different treatment options. So the three that can definitely cause problems with erections are surgery, radiation, and hormone therapy. Anything you do to the prostate is pretty much going to have a side effect. Okay, so it's very important to not let this drive your choices for prostate cancer. You need to do what you can to get a cure, because even if you do have issues, I can definitely fix that, or other urologists that are trained in it can fix it. So why does this happen? And the reason why is, if you look at these pictures, the nerves that control erections and also continence, so being able to hold urine in, are very intimate to the prostate. I know I talked about bladder, so the bladder is right here. If we're removing the bladder in a man, we're also taking out the prostate. So that's how you bag those nerves there. And then remember, Dr. Klassen talked about the rectum being right here. So imagine if we were taking out the rectum, again, those nerves would get injured. So we have had a lot of advances in treatment of prostate cancer, especially with the robotic surgery. However, the robot is not a microscope. We cannot save all these little nerves. There will be some sort of injury to the nerves, and there will be some sort of deterioration in your erectile function with treatment of prostate cancer. So what can you expect? So if you get radiation or surgery, you're probably going to end up with some bladder leakage. You're also going to have some erectile dysfunction. And with the hormone therapy, which I don't think Dr. Clausen really went into, but what that does is it blocks the testosterone, uses for patients who are very unhealthy, who can't undergo surgery or radiation, or if you've undergone one of those two things or both, and then you continue to have a rise in your PSA. So if you're blocking testosterone, of course, you're going to have a low testosterone, and most of these men, or pretty much all of them, are going to have some form of erectile dysfunction. So what about ED after prostatectomy? So the thing you have to understand, and I am a huge proponent of managing patients' expectations up front. I used to get on my attendings nerves. So attendings are the doctors that we work under when we're residents. One of my attendings used to tell his patients that they would get erections like the day after surgery, which is totally not true. I always wanted to tell them the truth, because the last thing I want is the first time you realize you don't have erections is once we take out your catheter and you go home and try to have intercourse. That's terrible, right? So a lot of times after prostatectomy, it may take a year or longer for you to regain that function. With the advent of with the robot, we've actually seen that you're going to get to your baseline function a lot faster because we're better at the surgery. The other thing is, if you come see me, we're going to go do some penile rehab. Okay. So just like if you had heart surgery, you go to cardiac rehab. If you have a prostatectomy, you're going to go through penile rehab. And what this does is it helps with the nerves and with the blood flow to the penis to help them recover after surgery. And the other thing is, if the ability does not recover after prostate surgery, there are treatments out there, so please do not despair. And that is my actual specialty. All right, so what is the actual definition of erectile dysfunction? So that is the consistent inability to sustain an erection sufficient for sexual intercourse. So this can be total inability to achieve an erection. This can be inconsistent ability to achieve an erection rigid enough for penetration, so you get like a partial erection, or the tendency to only sustain a brief erection, which means you lose the erection after you get one. So I'm a huge proponent of people learning more about what's going on with their body, because I believe if you understand what's going on, you buy into your care a little bit more. So we're going to go through how erections work. So first, you get excited. Once you get excited, the cavernous arteries will dilate, and then the blood will fill the corpora. Once the blood starts going to the corpora, so that's the erectile chamber, There we go. That tissue will expand. When that tissue expands, that's when you start noticing that you're getting the erection. So it's expanding out this way. Once it expands completely, it will go up against this wall here on the outside. And what it does is it closes off these little veins. So that prevents blood from draining out. Okay, so the main things is that you have a filling phase where the blood is going into the penis, and then you have a phase where you trap that blood in there. So what happens if you have what we call a failure to fill? That means you have that cardiovascular disease that we've been talking about. So you're starting to have plaques within the arteries, so there's not as much blood coming in. So then you never get fullness of the penis. So those are people who have slowness to get an erection, typically. And then what if you have a failure to store or a venous leak? So your arteries may be okay here, but then you have scarred tissue within the erectile chambers. So what that causes is this tissue is no longer elastic. So it won't stretch out to block off these veins. So that's when you get an erection, but you can't maintain it, or you have an erection and you change position and you lose it. That's what we call a venous leak. It's like having a nail in your tire. All right. So just to go into that a little bit more, again, I said you have the reduced expandability. So you have scar tissue within there. You have to have that tissue be able to expand to shut off those veins in order to store the blood. And when you can't do that, then you lose the erection. So why is it important to treat early and quickly? Is because if you don't, you'll have penile shortening. So remember I talked about having doing penile rehab with me. That's very important in my practice because we don't want you to get any shorter. What happens over time when you have prolonged erectile dysfunction that's not in check is that your penis will begin to shorten. It is a use it or lose it. So let's go through a little bit of recovery. Again, we talked about penile rehab and pelvic floor physical therapy or rehab. What these two things are is, again, with the penile rehab, I use a vacuum erection device. Oh, there we go. Sorry, I thought I had a picture of it. We use a vacuum erection device, and what that does is it helps pull blood into the penis. That way, when you're not getting the erections after surgery because the nerves are a little stunned, it continues to kind of mimic the spontaneous morning erections you used to get. The other thing I do with penile rehab is do a very, very low dose of the tadalafil or Cialis that I talked about earlier that we use with BPH. That medication will also help encourage the blood flow to the penis. I also will send you to a pelvic floor physical therapist. So this is a physical therapist that specializes in the pelvic floor. What they can do is help you control your continence better by teaching you how to contract those pelvic floor muscles. And sometimes I've had patients say that once they learn how to control that pelvic floor a little bit better, their erectile function will improve marginally. So that's another added bonus. So outside of that, what are the different treatment options that we have? So when I'm looking at a patient with erectile dysfunction, I always start with oral medications unless they have a reason why we can't do that. So those oral medications are like your tadalafil, your sildenafil, vardenafil is another one. I talked about vacuum erection pumps. I usually use that for just penile rehab because they can be uncomfortable and cumbersome during intercourse with the band that you have to put on there to prevent the blood from leaving out of the penis. I also use injection therapy. So that's injections that you put directly into the penis. I know it sounds horrible, but the silver lining is like with the pills, you have to wait an hour. With the injections, you're going to get an erection within 5 to 10 minutes if it's going to work for you. There's also urethral suppositories. I'm not a huge fan of those. They usually just cause urethral burning, but the VA loves them and all those patients do. And then my favorite is the penile implant. I'm sure everybody saw what that is, but does anybody know what this picture depicts here? Don't be shy. Somebody unmute themselves and Any guesses? I totally showed y'all the answer. No? All right. So what this is a picture of Lazarus. So what they used to call the penile implant back today was the Lazarus procedure because we bring it back from the dead. All right. So penile implants, again, like I said, this is my absolute favorite thing to do. This is what got me into urology, is watching my mentor, Dr. Ron Lewis, do one of these when I was a student. So the one that I typically use on patients is a 3-piece device. There's 2 different companies, and these are both of their products. They're very similar. So they both have 2 cylinders. Those cylinders sit within the erectile chambers of the penis. You have a pump that sits down in the scrotum, and then you have a reservoir that sits up in the abdomen. I know it looks like a lot of components, but literally my incision that I do is like this big, and that's it. I get all that in there through magic. And what you do is when you're ready to have intercourse is you're going to squeeze the pump. It's going to pull fluid from the reservoir here, and it's going to put it into the cylinders. So let's see if I can get this to play for y'all. So we'll go through it. Okay. So again, like I said, you have the reservoir that sits up in the abdomen. You have the cylinders that sit within the penis, and then you have the pump that's down in the scrotum. So what you do when you want to have an erection is you squeeze that pump, and it pulls the fluid from the reservoir and then puts it into the penis. I think it's pretty cool. I think it's magic. But anyway, then when you're done, the good thing about this is it stays up as long as you want it to. And as you saw there, he pushed this little button here. He's just putting gentle pressure on his penis and is putting the fluid back up into the reservoir. So this is an option for people who none of the other treatment options work. So we've gone through pills, we've gone through injections, we tried penile rehab. This is a great way for you to get a sustainable erection whenever you want for as long as you want. Let me go. All right. So now we're going to switch gears and talk about incontinence and how is it related to surgery and radiation for prostate cancer. So when I'm talking about incontinence, I'm specifically talking about stress incontinence. So that's when you leak with cough, sneeze, changing position, or heavy lifting. This can be arranged from just a few drops to a completely uncontrolled stream where you completely empty your bladder. After surgery, this will improve within several weeks to several months, up to years. Most patients will regain their control within a year. And the thing is, with persistent stress incontinence, this can affect your daily life. So I know a lot of men will definitely be more vocal about their ED, but stress incontinence is very debilitating. It's like, because with these men, they have to wear pads again because they're leaking. They don't want to have accidents. So it's very important that we treat them promptly. So how common is bladder leakage? So about 1 in 10 patients will experience stress incontinence for longer than 12 months after prostate cancer treatment. And if you're bothered by this, then we do have options. So there's things what I call coping options. So that's the pads that I talked about. You can use diapers depending on how bad the leakage is. You can also use catheter devices. So these are like condom catheters that you put on the outside of the penis, and then it has a tube that'll collect the urine, and it goes to a bag that you keep on the leg. There's external clamps. So a lot of my patients do use this. These put pressure on the penis to allow the urethra to be compressed to prevent leakage of urine. Again, we're going to talk about the pelvic floor physical therapy. This is the specialist that I send you to, and you can also do Kegel exercises on your own. And then the other thing is, and all these things are really good for very mild bladder leakage. So what are the surgical options that we have? So there's a couple different things that I do. We have the sling. So this is for moderate bladder leakage. What it does is it supports the urethra with a piece of mesh. It prevents you from leaking with stress. And the thing that patients love about this one most is, 1, you don't have any components that you have to manipulate in order to pee. And 2, you're continent right after the surgery. The biggest problem I have with patients is that they want to go home because they're like, oh, I'm dry, I'm gonna go do so many great things. You have to let these things heal into place, because if you go home immediately, then the sling will loosen and your incontinence will come right back. So this is the artificial urinary sphincter. It's the gold standard for stress incontinence. This is good for people who have moderate to severe or even persistent bladder leakage. There's 3 components, very similar to the penile implant. You have the urethral cuff, you have a pressure regulating balloon, and you have a pump. So this one mimics your healthy urinary sphincter. So at rest, it's closed. Okay. And then when you deflate the cuff, you squeeze that pump and it opens it up, and then you're able to urinate. And the amazing thing about this is it automatically reinflates itself. So you don't have to do anything. So it takes usually about 90 seconds for it to go back up. All right. So now we're going to talk about testosterone. Okay. So testosterone, or low testosterone, is becoming more and more in the public eye. Time magazine did this cover where it talked about menopause, or what we call late onset hypogonadism or low testosterone. It's huge, especially with the new aging. Like everybody wants to prevent aging and find that fountain of youth. Unfortunately, testosterone is not a fountain of youth, but it definitely can make you feel better. So ways to know that your testosterone is low is sometimes you'll have symptoms and signs. The main ones are reduced energy, reduced sex drive is another one, change in erectile function. But again, we can fix your testosterone. That may not fix your erections, because remember, erections are mainly to do with blood flow. And fatigue is another one. So some of the signs that you may see: you may have increased body mass, decreased muscle mass. You'll have decreased testicular size. You'll have loss of body hair. So those are the main things that men will say that they've noticed when they come in. So there's a lot of different treatment options that we have. And the ones that I highlighted in yellow are the ones that I typically use. Clomiphene is an oral medication. We have a lot of transdermal agents. So that just means stuff you put on your skin. I typically use the gels and the FDA regulated gels at that. And then there's also injectable stuff that's short acting, that you get injections every 1 to 2 weeks. So what is it that you need to know? There's variations with how much are absorbed, especially with those gels. So when you put gels on, not everybody's skin will absorb them well. With the injections, you can have peaks and valleys. So we're doing the injection, it's a depot injection. So you get it and then your body uses it up. So that means as soon as you get it, you're really high, and then your body starts to use it up, and then you go into this valley, and then you get it again. Some people really don't like the way that feels. Another important thing is if you go on actual testosterone, you will become infertile. Again, you will become infertile. It's very important. I can't tell you how many men are started on these agents and have no clue that this is going to change their fertility. I always ask those patients, and if you're thinking about this and you want to remain fertile, then you should see a specialist that can do other options for you. The other thing is you can have increase in hemoglobin. So that's like your red blood cells. It's very important that we follow that. Recent studies have shown that there was a question of whether testosterone treatment in cardiovascular disease was related. What they found the link is actually having a high hemoglobin. So it's very important that when you're getting on these medications, that whoever's prescribing them to you checks your blood work every 6 months, just to make sure everything is okay. The other thing is you can have increase in estrogen. So yes, men have estrogen. It's made from testosterone. So if I'm increasing your testosterone, then your body may shunt some of that over to estrogen. As long as you're not having any symptoms, I'm okay with you having it shunted over, because again, you do need some of it. So that's just something to keep an eye on. And if it does get high and you do have symptoms, we can either lower your testosterone dose, or there's medications that we can start to try to help that. Again, testosterone itself is not linked to cardiovascular disease, or getting replacement isn't linked to it. What it is linked to is if you look at it, right? So as men age, their testosterone lowers. As men age, their heart risk goes up. So probably the more likely risk is that having a low testosterone causes problems with cardiovascular disease. The other thing is that giving testosterone itself is not linked to prostate cancer. I know a lot of people are scared to get on it because of this. Another thing it's not linked to is having blood clots. This may not improve your erectile dysfunction, and you should be aware of over-the-counter medications and supplements. So it's very important that if somebody puts you on testosterone, you should not go out and get some over-the-counter testosterone supplement, okay? Because then you're going to cause issues where your levels are going to be out of whack, and it's going to be hard for that practitioner to be able to manage it. So I have talked your head off enough. Does anybody have any questions?
Yes, Giant Holmes, I do have a question.
I'm sorry, go ahead.
Can you hear me?
John. Yeah, go
Oh,
ahead.
okay. I was tested one for testosterone level, and the stuff that they wanted to prescribe seemed like there was just too many side effects or possible side effects, and I thought that was too much of a risk.
So what were they trying to start?
This was this been what 20 years ago.
So like more and more literature has come out about testosterone and what it actually causes issues with. If you're interested in it, I would say just go to somebody who deals with low testosterone a lot, and they'll be able to navigate those waters with you. The main side effects that go along with just like the short acting ones are mood swings, but that's if your levels get too high. That's why I always check people's levels regularly. The other thing is having oily skin, having increased body hair, which usually is not a problem for most of my patients. So if it's something you're interested in, if you're really truly having a lot of fatigue from having a low testosterone, it's pretty safe to on. I will say though, if you're on it or if you're about to start it, if you've had like a cardiovascular event, so saying like a stroke or a heart attack, or even blood clots in your legs, we typically won't start that within 6 months to a year of you having that event. And that's just to make sure that everything is okay. But other than that, I have plenty of patients that are on it.
Okay, thank you.
Dr. King.
Yes.
Wyman Smith. You've covered a lot there in this tonight. You really covered a lot. I just kind of went over, under, but anyway, let's get back to ED here. I was looking at ED.
Yes.
You know, I was wondering, you talked about, the 4 different, methods of ED. You can use pills, pumps, all these different things.
Mm-hmm.
I'm just wondering now, you go to your primary care physician maybe,
Mm-hmm.
or should you go to a specialist when you're dealing with ED, rather as opposed to, because, you hear so many stories. So you say, this guy he was taking the pill and man, he just took 5 or 6 pills and wow, he just went on out of here, So you just, you're covering so much here. So I'm just wondering, should you just not go to your primary care physician, anything basically like that? Or should you go to professionals maybe?
Yeah, so yeah, you can start with your primary care physician. Okay. So what they can start you on is the oral medications, and that is fine. Now, if somebody takes them like they're not supposed to, right, that's not the fault of the primary care.
I understand.
Right. The other thing is what a lot of people do not understand. If these medications actually started out as heart medications. So Viagra first was made because of people who had chest pain. Okay. And they tested it on these people. And what they found is that they had more erections at night. And they were like, well, this is awesome. We can make a lot of money from it. So they decided to go a different route. And it totally changed the world of sexual medicine. Right. So it's not going to make you have a heart attack. Now, an important thing is to remember, like, what is your baseline function? Because I've had patients come to me who are like, on a walker, sucking on oxygen, and are like, make me have sex. And I'm like, dude, if you can't even walk into my office without like passing out, you can't have intercourse. So it's those patients who are unhealthy that are given these medications and they overexert themselves. Yeah, they're going to have a heart attack, right? There's some patients, like I had a patient who was like, oh, my doctor told me not to walk further than a quarter mile. How are you going to have intercourse? Like, how did you think this was going to happen? And he thought I had some magic. I wish I had magic. I'd be really rich. I don't have. All I can do is what your body will allow. So I'm a huge proponent of making sure that my patient is overall healthy. That's why I always talk about like hypertension, diabetes, and cardiovascular disease, because it's very important to control these things.
Okay. All right. Thank you.
I have are you finished, Wanda?
Yeah, I'm finished, y'all. Go ahead.
I have a question about the nerves that are in the prostate, which affects your ED. And are there any research on that as to identifying which nerves are responsible for erections? And I know one of the terms that when I was having mine, it was being nerve sparing. Can you talk about that, or do you know, or are there any more research about that, trying to identify those nerves that are responsible for that?
Yeah, so we do know what nerves are responsible for it, but the thing is that there's no way to be able to completely separate those nerves from the prostate. Like I said, with the advent of the robot, it made it a lot better. It definitely did, because that way you see the planes a little bit. You can see the planes a lot better, actually. When you're doing a prostatectomy, you're pretty far from it, and nobody's eyes are microscopes. But the thing is, that robot isn't a microscope either. We can't tease out every one. And in order to get the prostate out, there's a lot of maneuvering we have to do with the gland itself, and that puts tension on those nerves. So even if we don't cut them and we leave what we call veils of Aphrodite, we try to move them aside, they're still going to be stunned. There's still going to be some sort of trauma to those. And that, I don't know. You got anything to add, Zach? Because I haven't done a prostatectomy in a long time.
But I think. Do you think that as we progress down the road with this technology, that someone may come up with a better idea or a better device for that robotics, whether or not it be type of material that they use or whatever? Do you see that down the line?
It's a good question. I think, unfortunately, I don't think so, because the visualization with the robot is 10-time magnification on a screen. It's three-dimensional. It's like we're sitting right there looking at the prostate with great magnification, 6 degrees of freedom on the instrument. And there's going to be nuances to how we do robotic prostates in terms of, single port and all this stuff that's going to be getting more minimally invasive.
Right.
From a purely surgical standpoint, as Dr. King said, those nerves, we know where they travel. They kind of come underneath the prostate and then they go alongside. So we move them off. But even if we move them off, and as Dr. King mentioned, there's some pulling on the prostate to get it out, there's always going to be some degree of stunned or trauma to those nerves. That is, no matter how good the technology get, I think is always going to be there.
Okay.
Now, I think Dr. King probably mentioned what you come in with function wise and what you come out with is somewhat correlated, but it's never, don't let anybody, no matter who you see as urologist, don't let anybody ever tell you that it's going to be the same.
Right. I understand.
And that's just being the God's honest truth, because there's a lot of people in this country that take prostates out that will not even talk about erectile dysfunction, or they'll tell you that it's going to be the same, or that it won't be affected, that you'll be back to the same that you were in 3 days or even 3 months. This is all nonsense, because the way that this operation is done, and probably will be done, for the next 100 years, is just, there's going to be some degree of trauma to those nerves, no matter how well the nerves are spared.
Correct. Okay. Thank you.
Good question.
Dr. King, you're at the VA uptown?
Downtown. So all the surgical subspecialties are downtown.
Okay, all right.
Yes, but if you want a appointment with me, you have to get your primary care doctor to put in the consult, but just make sure they put my name in the consult. I'm only there on Wednesdays, so make sure they schedule your appointment for Wednesday clinic.
All right, thank you very much.
The one thing I will say, just I think sort of an overarching theme of the whole evening between Dr. King's talk and my talk is all of the early screening, and we talked about, and the importance of early detection. The overarching theme for our combination talk is these side effects are real and nobody likes them and nobody wants them. But as Dr. King mentioned, don't let that fear be the driving force to not get screened, because I swear to you, I will send you to her, and what she does for these patients that I take their prostates out or their advanced prostate cancer, they got them on hormone therapy. What I have to do to get the cancer under control, she's phenomenal in helping with those side effects that she talked about. And I think if you remember anything from this talk, don't let that fear drive a lack of, talking about screening or coming and getting checked or getting treatment if you need it, because it's those side effects are scary and nobody wants them. But the reality is that if you have a window to cure prostate cancer, if it needs treatment, it's there. And her entire practice is built around helping these men get back to where they want to be. So I wanted to make sure that was said before we sign off.
Thank you. Are there any other questions, comments? All right. Mr. President, I can turn it back over to you.
I'm sorry. Phil.
Yes.
Wyman Smith.
Go ahead.
Any other questions or comments? I just like to say that I thank both of the Dr. K's there for filling us in. They did a great job. I really picked up a lot of information tonight, and hopefully I can carry some of this over. Thank you very much.
All right. Thank you. Yeah, my sentiments the same as Mr. Smith is that it was great. I really enjoyed this, and I know we ran over time a little bit, but I think it was worth it. And I appreciate all the questions that people had, and hope we can do another one like this on some other topics during the course of the year. Mr. President.
All right, thank you, Brother Lavner. Like I said, we ran over a little bit, but it was worth it. It was worth it. This was some really good information. And I like the fact that we're going live, so that means that, and it's being recorded so others can see that are not on tonight. Dr. King, Dr. Clausen, I thank you greatly for the information that you have shared with us. And that's it. I hope everyone have a great night.
Okay.
Thank you, everybody. Appreciate the time. Have a great night.
All right. Sure. Hey, brother, let me stay on for a while. I got to ask you a couple questions.
Brother I need the host back, Dr. King.
Huh?
I need the host back.
Oh, my bad. I'm sorry.
That's okay.
She gonna go into the other meeting with us.
I know. I think y'all probably tired of me. I don't want to hear about erection. Wait, so okay.
Brother,
at the bottom. Wait, how do I give you the host back?
Just click on Alpha Chi Lambda.
Okay.
And then say make host.
I got you.
Brother, oh, sorry.
Thank you, Sharita.
All right, bye.
Bye.
Brother Lavender, he said he was going to send you the slides. Could you email them to me as well so I can put it in?
I will definitely do that.
I'll send you email address so I can put it in the notes for the chapter meeting.
Oh, okay. Okay. Brother, all right. I had a couple of people couldn't get on, but they wanted to get a copy of the recording. Can we do that? How do you do that?
Are we still live, brother?
What you mean they couldn't? What you mean they couldn't get on?
They couldn't get on.
We still live?
Yeah, we're still live.